Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 178 of our Pharmacotherapy MCQ series, which majors in infectious diseases. AKL is newly diagnosed with HIV infection and pneumocystis jirovecii pneumonia. He has been receiving appropriate treatment for his opportunistic infection in the hospital's medical intensive care unit for the last 5 days. He has had considerable improvement and will be transferred to the general medical ward. Some of his pertinent labs include a serum creatinine of 0.8 mg per deciliter, AST of 15, ALT of 25, CD4 of 115 cells per millimeter cubed, and a viral load of 187,000 copies per milliliter. Resistance testing negative, HLA-B star 5701 positive, HBsAg, negative, anti-HBs. Positive, anti-HBcIgG positive, anti-HCV negative. So my question to you is, which of the HAART regimens listed below would you recommend for ALK now? Would it be A. Initiate Raltegravir, Cobi-C-Stat, Tenofovir Alafenamide, and Emtricitabine, marketed as Genvoya, after 14 days of therapy for his opportunistic infection have been completed, or B. Initiate Raltegravir, Isentress, Tenofovir Alafenamide and Emtricitabine, marketed as Descovy, 14 days after treatment for his opportunistic infection has been completed, or C. Initiate Dolutegravir, Abacavir, and Lamivudine, marketed as Triumeq, 14 days before the treatment of his opportunistic infection is completed, if possible, or would it be D. Initiate Dolutegravir, Tivicay, Tenofovir Alafenamide, and Emtricitabine, marketed as Descovy, within 14 days after starting treatment for his opportunistic infection, if possible? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Initiate Dolutegravir, Tivicay, Tenofovir Alafenamide, and Emtricitabine, marketed as Descovy, within 14 days after starting treatment for his opportunistic infection, if possible. Based on available data from clinical trials and recommendations from the CDC, NIH, and HIV Medicine Association, antiretroviral therapy should be initiated within 2 weeks after starting treatment for pneumocystis pneumonia, if possible. This answer choice is the only option that is consistent with this recommendation and provides a safe and appropriate treatment option for this patient. Regimen C is not recommended because the patient is HLA-B star 5701 positive, which places the patient at increased risk of a severe hypersensitivity reaction to abacavir. Regimen B provides an appropriate antiretroviral therapy recommendation, but the timing of initiation 2 weeks after completion of treatment for the opportunistic infection is suboptimal. Initiation of ART within 2 weeks after starting treatment for his opportunistic infection is preferred. Option A provides an appropriate antiretroviral therapy recommendation, but the timing of initiation 2 weeks after completion of treatment for the opportunistic infection is suboptimal. Initiation of ART within 2 weeks after starting treatment for his opportunistic infection is preferred. Please proceed to the next question. And the next question reads, TPN is diagnosed with HIV infection and cryptococcal meningitis. His baseline CD4 cell count of 89 cells per millimeter cubed. He has received appropriate treatment for the acute opportunistic infection and is currently receiving oral fluconazole 200 mg once daily as maintenance therapy in addition to HAART. TPN has received 14 months of treatment for his opportunistic infection and is also currently receiving prophylaxis for pneumocystis pneumonia and toxoplasmosis with co-trimoxazole. His HIV viral load is currently undetectable. His current CD4 cell count is 185 cells per millimeter cubed. It has been over 100 cells per millimeter cubed for the last 3 months. So my question to you is, which of the following would you recommend regarding TPN's opportunistic infection treatment and prophylaxis regimens? Would it be A. Discontinue Co-trimoxazole, but continue fluconazole until the CD4 cell count is greater than 100 cells per millimeter cubed for at least 6 months, or B. Discontinue fluconazole, continue co-trimoxazole until the CD4 cell count is greater than 200 cells per millimeter cubed for at least 3 months, or C. Continue both fluconazole and C-trimoxazole until the CD4 cell count is greater than 200 cells per millimeter cubed for at least 6 months, or would it be D. Continue both fluconazole and co-trimoxazole until the CD4 cell count is greater than 200 cells per millimeter cubed for at least 3 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Discontinue fluconazole, continue co-trimoxazole until the CD4 cell count is greater than 200 cells per millimeter cubed for at least 3 months. Fluconazole can be discontinued at this time since more than a year of treatment for cryptococcal meningitis has been completed, the patient is asymptomatic, and he has seen his CD4 cell count rise to above 100 cells per millimeter cubed in response to ART for at least 3 months. Trimethoprim, sulfamethoxazole should be continued as prophylaxis for pneumocystis pneumonia and toxoplasmosis as long as the patient's CD4 cell count remains below 200 cells per millimeter cubed, according to opportunistic infection treatment guidelines. Please advance to the next question. And the next question reads, KLM, a 25-year-old male patient with newly diagnosed HIV infection and a baseline CD4 cell count of 32 cells per millimeter cubed has confirmed disseminated Mycobacterium avium infection upon presentation to your hospital. His currently treatment includes azithromycin 600 mg once daily, ethambutol 1200 mg once daily, and rifabutin 300 mg once daily. KLM will begin HAART in the coming days. His current vitals and pertinent labs include a blood pressure of 127 systolic and 84 diastolic, a heart rate of 68 beats per minute, a respiratory rate of 18 breaths per minute, a body temperature of 98.6 degrees Fahrenheit, a weight of 80 kilograms, a height of 5 feet 9 inches. His pertinent labs include a serum creatinine of 1.0 mg per deciliter, an AST of 18, an ALT of 26, a CD4 of 38 cells per millimeter cubed, and a viral load of 215,000 copies per milliliter, an HIV resistance testing negative, toxoplasmosis IgG negative, G6P, D deficiency negative, HLA-B star 5701 negative, HBsAg, negative, anti-HBs, negative, anti-HBc, IgG negative, anti-HCV, negative. So my question to you is, which of the pharmacotherapy plans listed below would be the most appropriate for KLM's HAART? Would it be A. Initiate Raltegravir plus Tenofovir Alafenamide and Emtricitabine, but increase Raltegravir to 800 mg twice daily, or B. Initiate Elvitegravir, Cobicistat, Tenofovir Alafenamide, and Emtricitabine, but decrease Rifabutin to 150 mg once daily, or C. Initiate Dolutegravir, Abacavir, Lamivudine and make no adjustments to the KLM's antimycobacterial therapy, or would it be D. Initiate Dolutegravir plus Tenofovir Alafenamide and Emtricitabine, but increase Dolutegravir to 50 mg twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiate Dolutegravir, Abacavir, Lamivudine and make no adjustments to the KLM's antimycobacterial therapy. None of the antimycobacterial agents interact with Dolutegravir, but Rifabutin should not be co-administered with Tenofovir Alafenamide because concentrations of Tenofovir will be considerably reduced. Regimen C is the best choice because it provides a single tablet HIV regimen with no significant drug-drug interactions. Although Dolutegravir undergoes metabolism by CYP3A4 enzymes, the enzyme induction by Rifabutin and impact on Dolutegravir metabolism are minimal, i.e., the interaction is not clinically relevant. Therefore, no adjustments are needed to this patient's antimycobacterial therapy. Elvitegravir, Cobicistat and Tenofovir Alafenamide levels decline considerably when administered with Rifabutin. The use of this combination is contraindicated. Rifabutin does not interact with Raltegravir or Emtricitabine, so there is no need to increase the Raltegravir dose if these drugs are used concurrently. However, Rifabutin should not be co-administered with Tenofovir Alafenamide because concentrations of Tenofovir will be considerably reduced. Please proceed to the next question. And the next question reads, what advantage does Tenofovir Alafenamide abbreviated as TAF have over Tenofovir Disoproxil Fumarate, abbreviated as TDF? Is it A. TAF is more effective for reducing HIV viral replication than TDF, or B. TAF has been associated with lower total and LDL cholesterol levels than TDF, or C. TAF has been associated with less renal and bone toxicity than TDF, or is it D. TAF is available as part of a single tablet antiretroviral therapy product but TDF is not? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. TAF has been associated with less renal and bone toxicity than TDF. Both drugs are available in several single-tablet ART products. In a number of clinical trials comparing the two agents, the risk of kidney injury and bone mineral density losses were lower with TAF than TDF. TAF has been associated with higher total and LDL cholesterol levels than TDF. There is no evidence that TAF has greater activity against the HIV virus than TDF. Please advance to the next question. And the next question reads, JOS, a 27-year-old male patient is referred to your HIV pre-exposure prophylaxis, abbreviated as PrEP clinic after testing negative for HIV and sexually transmitted infections 60 days ago. JOS has sexual intercourse with about 5 male sexual partners each month and they use condoms most of the time, but not always. His physical exam is unremarkable. He has no significant past medical history apart from completing a course of oseltamivir 7 days ago. His renal function is normal. He currently takes no medications. So my question to you is, which of the strategies listed below would be the most appropriate with regard to JOS's request for PrEP? Would it be A. Initiate Tenofovir Disoproxil Fumarate, Emtricitabine, marketed as Truvada, as PrEP, but only after confirming that the patient is hepatitis B virus negative, or B. Initiate Tenofovir Disoproxil Fumarate, and Emtricitabine, Truvada, as PrEP today, and see the patient again 90 days from now for follow-up HIV testing, or C. Initiate Tenofovir Disoproxil Fumarate, Emtricitabine, Truvada, as PrEP, but only after assessing the patient's HIV and hepatitis B virus status, or would it be D. Initiate Tenofovir Alafenamide, Emtricitabine, Raltegravir, Cobicistat, marketed as Genvoya, until confirming that the patient is HIV and hepatitis B negative, then initiate Tenofovir Disoproxil Fumarate, Emtricitabine, Truvada, daily. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiate Tenofovir Disoproxil Fumarate, Emtricitabine, Truvada, as PrEP, but only after assessing the patient's HIV and hepatitis B virus status, or would it be? There is no evidence of a need to initiate a complete antiretroviral therapy regimen in this patient as a bridge to PrEP. A complete antiretroviral regimen would only be indicated if the patient's HIV test returns with positive results, and PrEP would be inappropriate in that situation. Before initiating PrEP, clinicians should assess the risk of HIV infection and eligibility for PrEP based on the CDC guidelines. This patient is at substantial risk since he is a man who has sex with men and uses condoms inconsistently. His eligibility for PrEP is unclear because he has not been tested for HIV in 2 months and he may have been exposed to HIV since then. Therefore, the patient's negative HIV status must be confirmed prior to initiating PrEP. Because the PrEP medications are also active against hepatitis B virus, the patient's hepatitis B status also should be confirmed. If the patient has HIV infection and PrEP is initiated without confirmatory testing of his HIV status, there is a considerable risk that resistance to the PrEP medications will develop in the HIV strains in his body. The medications should not be started until the patient has confirmatory HIV negative test results. Please proceed to the next question. And the next question reads, which of the following corresponds to the maximum number of pneumococcal immunizations? 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, and 23-valent pneumococcal polysaccharide vaccine, abbreviated as PPSV23, that adult patients living with HIV infection are eligible to receive while under the age of 65 years old, according to the Centers for Disease Control and Prevention. Is it A. 3, or B. 2, or C. 1, or is it D. 0? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. 3, because they are considered to be immunosuppressed. Persons living with HIV infection should receive pneumococcal immunization. Patients living with HIV infection under the age of 65 are advised to receive 2 PPSV23 immunizations at least 5 years apart in addition to 1 PCV13 immunization, so the maximum number of pneumococcal immunizations is 3. Please proceed to the next question. And the next question reads, how soon after the initiation of HAART should a patient's viral load first be measured to evaluate the treatment response? Should it be A. 12 months, or B. 6 months, or C. 3 months, or should it be D. 1 month? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. 1 month. The HIV viral load is the primary laboratory value that should be monitored closely following ART initiation. A typical response to treatment is rapid, and patients should achieve at least a 10-fold decline in their viral loads within 2 to 8 weeks of treatment. Many patients will have achieved an undetectable viral load within 3 months after starting ART. However, for patients experiencing side effects and/or not maintaining proper adherence to therapy, treatment failure can occur prior to 3 months with the development of resistance. Therefore, the response to ART should be evaluated within 2 to 8 weeks after initiating therapy. Delaying this assessment can prevent clinicians from identifying early treatment failures and the development on resistance. All patients should have achieved virologic suppression within 12 months after starting ART, with the response to therapy measured 2 to 4 times in this period. The frequency of measurement of both viral loads and CD4 cell counts can decline over time once patients demonstrate a durable virologic and immunologic response to treatment. Please progress to the next question. And the next question reads, TNA, a 63-year-old male patient who was diagnosed with HIV infection 5 years ago but is treatment naive, presents to your HIV comprehensive care clinic today to initiate HAART. His current labs include a CD4 cell count of 378 cells per millimeter cubed, an HIV RNA level 115,000 copies per milliliter, and he is hepatitis B and C negative. His HLA-B star 5701 testing is negative. His HIV resistance testing is negative. 7 days ago, TNA was seen by his primary care physician and initiated on simvastatin 20 mg at night due to his elevated risk for cardiovascular disease. He has a past medical history significant for hypertension, chronic kidney disease with an estimated glomerular filtration rate (eGFR) of 60 ml per minute, type 2 diabetes mellitus, and his recent A1C level was 7.2%. His other medications include lisinopril 20 mg orally once daily, hydrochlorothiazide 12.5 mg orally once daily in the morning, aspirin 81 mg orally once daily, subcutaneous insulin glargine every evening, and insulin lispro thrice daily with meals. So my question to you is, which of the following courses of action would be the most appropriate for TNA's medications and HAART? Would it be A. Increase hydrochlorothiazide to 25 mg once daily and initiate Raltegravir, Isentress, plus Tenofovir, Disoproxil, Fumarate, and Emtricitabine, marketed as Truvada, as his HAART, or B. Change simvastatin to rosuvastatin 5 mg at night and initiate Raltegravir, Cobicistat, Tenofovir, Alafenamide, Emtricitabine, marketed as Genvoya, as his HAART, or C. Change lisinopril 20 mg once daily to losartan 50 mg once daily and then initiate dolutegravir, Tivicay, plus Tenofovir, Alafenamide, Emtricitabine, marketed as Descovy, as his HAART. Or would it be D. Make no changes to his medications and initiate dolutegravir, abacavir, lamivudine, Triamec, as his HAART? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Change simvastatin to rosuvastatin 5 mg at night and initiate Raltegravir, Cobicistat, Tenofovir, Alafenamide, Emtricitabine, marketed as Genvoya, as his HAART. Although there are no substantial drug interactions between the HAART regimen in D and the patient's medications, the DHHS-HIV treatment guidelines recommend considering avoiding abacavir in patients like this one with a high risk for cardiovascular events. HAART regimen C would be a reasonable option to initiate for this patient. It is safe and effective, will have minimal impact on his cholesterol levels, and will not interact with his medications. However, because there are no significant drug interactions, there is no reason to change his lisinopril to losartan. Simvastatin is a CYP3A4 substrate that has significant drug interactions with a number of antiretroviral agents, including ritonavir-boosted protease inhibitors, i.e., darunavir, ritonavir, and boosted integrase inhibitors, i.e., Raltegravir, Cobicistat. Cobicistat is contraindicated with simvastatin, because cobicistat is a strong CYP3A4 inhibitor that inhibits the metabolism of simvastatin. Changing simvastatin to rosuvastatin, a CYP2C9 substrate, avoids the drug interaction and allows for the safe and convenient administration of both this ART regimen as a single tablet and lipid-lowering therapy. Lisinopril, hydrochlorothiazide, aspirin, and insulins do not have significant drug interactions with Raltegravir, Cobicistat, Tenofovir, Alafenamide, Emtricitabine, Genvoya. HAART regimen A does not interact with this patient's medications. However, this patient should not be started on Tenofovir Disoproxil Fumarate because of his chronic kidney disease and the potential adverse impact of the drug on renal function. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 179.